Of course, you are courageous to be that late in the afternoon to listen to the last session of secondary headaches. Our first speaker is Dr. Mudar Khalil of UK, Yorkshire, who will be speaking about diagnosis of secondary headache, emphasis on the Middle East. Dr. Mudar.
Thank you very much. My name is Mauda Khalil, as they say in English. In Arabic, it's Mudar Khalil. I'm a consultant neurologist practicing in the UK. I appreciate that this is the penultimate session and everybody is saturated, so I'm going to try to be quick. So the topic of my talk is going to be about diagnosis of secondary headaches in the Middle East. Of course, I'm not going to be able to cover everything, so I'm going to concentrate on one important condition. The outline of my talk, I'm going to mention few definitions to start with. They will be boring to you, I know that. Then a bit of an overview on articles published in the Middle East about secondary headaches over the last 10 years, followed with public health challenges in the Middle East and North Africa. Mainly I'm concentrating about obesity, and you've guessed that by now. The topic would be, the secondary headache would be linked to that, would be IIH. Mainly I'm going to concentrate about diagnostic pillars and their challenges. So the International Classification of Headache Disorders has given us this quite comprehensive definition of secondary headaches. I tend to prefer the Americans. They are very straightforward with their definitions. It's just a secondary headache. It is secondary when it's caused by other conditions. Those are kind of quite probably boring examples for you. And when we talk about the Middle East, this is an area comprised of 17 political entities according to the United Nations. It's slightly smaller than Australia, with a population of that less than the United States. Climate-wise, it's a quite homogeneous area. It's mainly arid and semi-arid climate. Economically, it's quite a heterogeneous area, with one of the countries having one of the highest GDPs in the world compared to others with having the lowest. That, of course, has an implication on types of health challenges that the area faces. When I started preparing for this talk, I thought, okay, let's have a look at PubMed about what has been published over the last 10 years in medical literature about secondary headaches from the Middle East, and came up with about 498 articles. And when I went sieving through them, it's actually only about 110 articles discussed secondary headaches coming from the Middle East. And when I looked at which countries were taking the lead in those articles, Turkey and Iran were the top publishers. When I looked at those 110 articles by etiology, interestingly, the commonest type of etiology report is communicable diseases, mainly infectious, and the commonest would being neurobruscellosis, followed by Congo-Crimean hemorrhagic fever. And why this is interesting? If we look at public health challenges in the Middle East, looking at this article which has been published in 2006, by the year 2000, 45% of the disease burden comes from non-communicable diseases, compared to 40%. And this gap is set to get even wider by 2020, with 60% of the disease burden coming from non-communicable diseases. And this is thought to be linked to rapid urbanization and change in lifestyle in the Middle East. One important health challenge and public burden in the Middle East will be obesity in this case. I was really surprised to find out that adults in the Middle East have the highest mean BMI after that of the US, and women tends to have the highest waist-to-hip ratio. More interestingly, apparently, according to this article which was published in 2012, the prevalence in obesity in the high-income countries in the Middle East compared to that of the middle income is thought to be very similar. And hence, the author thought that actually this is probably linked to cultural rather than economic etiology. In this article as well from 2012, again, another surprise to me, Kuwait is taking the lead in the prevalence of people having high overweight being overweight and above. And this is set to get even worse if nothing has been done about it. Now, obesity and IH. Obesity has been always linked to IH in all published studies. Weight reduction has always led to improvement in the intracranial pressure, improvement in papilledema, and potentially headaches. Mechanistically speaking, the relationship between the two is very, very unclear. Obesity is common on one hand. On the other hand, IH is still rare. Why this is important? Well, in a study that's published in 1982, it's thought if you leave patients untreated, you are looking about a quarter of your patients ending up with permanent visual loss. And one study published in the UK, 1 to 2% of new cases will be registered as blind each year. More relevant to the topic I'm presenting is the disabling headache in the majority of them. And even in many cases, when you treat IIH properly, the headache doesn't really remit easily. Again, going back to the ICHD3, I find the definition is quite complicated, quite comprehensive, and I think modified anti-criteria will do us well. Straightforward, down to the point. The only thing probably, the cutoff CSF abnormality pressure would be about 25 rather than 20. Again, in the last 10 years, I looked up at each country's publication in the IIH field, and Israel and Turkey are taking the lead. When we talk about annual incidence of IIH in the Middle East, Sumaya Marzougi and her colleagues published in 2015 a summary of all previous studies that have been published in the Middle East. And we only know about the incidence in 3 countries. Israel having 2.02 adults per 100,000, females 3.17, Oman 2.8 adults and 3.25 females, and Libya, to my surprise again, is the highest incidence in the world with 2.2 adults and 4.3 females. If we were to compare that to that of the United Kingdom, for example, this study published in Sheffield, which is a medium-sized city in Yorkshire, the adult incidence was 1.56, female 2.86. And if you look at the States, this study comes from New Orleans with an adult incidence of 1 per 100,000 and females 2.55. Now, if we were to look at the incidence in obese female, the incidence is much, much higher. We're talking about at least 13 to 20 per 100,000. This lovely case-control study published in 1991 and looked at the top symptoms that could differentiate people with IIH. And the top 3 were headaches, transient visual obscuration, and pulsatile tinnitus. When we look at them, headache typically, as you all know, is an orthostatic headache. The patient will wake up with headaches and carry on with headaches, and the headache tends to get worse when they bend over or lay flat. With the TVO, or the transient visual obscuration, typically the patient will describe dimming or graying of vision. I always found that much more common than people saying that it goes black, and it can be in either one eye or both eyes, and typically it's orthostatic, lasts for seconds only. Having TVOs doesn't really predict long-term outcome with vision. Pulsatile tinnitus is very important, and usually is overlooked by patients unless you really ask the patient directly whether they have any pulsatile tinnitus or not, and often it's unilateral. Interestingly, diplopia happens in about 10 to 20% of cases secondary to sixth nerve palsy. After taking a good history, you need to examine the patient, and the most important part will be this, and having this appearance will be kind of reassuring to know in a patient that, especially when the history is a bit dodgy about IIH. Now, spontaneous retinal venous pulsation is present in about 90% of normal population, and at the point of checking it, that tells you more or less you'll be reassured at that point the CSF pressure is normal. However, that does not rule out IIH. In the end of the day, it's a clinical entity, so you have to bear in mind the history that you were given. The next step when you see a papilledema is to grade it, and typically you start from grade 1. This is Frisen grading system where grade 1 is given when you see this C-shaped, I don't have a pointer, you can see a C-shaped halo within the disc with gap in the temporal side. And when it becomes all over the disc, it's grade 2. And in grade 3, you start to have attenuation in a vessel or more than one vessel as it crosses the disc. And finally, when all of the vessels are obscured, this is called an angry optic disc. Now, the problem with this system that even neuro-ophthalmologists will disagree among other in terms of the grading system. So this study was published in 2010, and the concordance rate among 4 neuro-ophthalmologist was only 55%. That leads us to kind of probably utilizing other modalities of investigations such as OCT. It's quite reliable at lower grade of papilledema. However, at higher grade tends to overestimate the degree of papilledema. It requires patient cooperation, but on the other side, you'll not be kind of constricted due to pupil size or cataracts. The caveat to when you're dealing with papilledema is the possibility of having other things that could look like a papilledema. I'm going to concentrate only on optic disc drusen. Optic disc drusen have prevalence about 2% of eye biopsies. They tend to calcify with age, and that kind of help us in terms of investigating them when you do the ultrasound scan B in the globe. I would certainly wouldn't recommend a CT scan of the brain or the globe to look at drusens. And when it's present in one eye, it tends to be 75% bilateral. And if it's familial, it tends to be inherited via autosomal dominant trait. Now, most of the people with optic disc drusen, they tend to be asymptomatic, especially kids, because they tend to have it buried deep in the optic disc, and as they grow older, they tend to become more superficial, and when it starts to cause some grief. And the commonest thing will be really visual field defects. That happen about, according to one article, from 2 to 10% of cases, and mainly it's enlarged blind spot or arcuate scotoma in the inferior nasal margins. However, retinal hemorrhages and non-arthritic ischemic anterior optic neuropathy are not unheard of. Neuroimaging, well, where I practice, it's quite a busy place. I work in a government, well, it's called the NHS, and we get a lot of referrals, especially in the last 6 months. There has been a legal case in the United Kingdom where a papilledema has been missed by an optician, and that caused chaos, and everybody was panicking. And now the opticians have a very low threshold to refer patients to ophthalmology because of suspected papilledema. And access to MRI scan in my hospital is very, very difficult on an acute basis. So I tend to send the patient straight away to CT, CTV, and all of them will end up having an MRI, MRV within the next 3 to 4 weeks. Why MRI, MRV? Because it's very good in terms of ruling out other conditions that could mimic IIH or give rise to raised CSF pressure. And at the same time, you will be looking for some features that could suggest the raised CSF pressure. So for example, an empty cella, which can happen in about 70% of people with IIH, or a bulging of the optic disc and tortuosity of the optic nerve, that could happen about 45% of people with IIH. And lastly, some attenuation in the distal transverse sinuses that could as well happen. It was found that the flattening of the posterior globes to be very specific. In one study that published in 2008, it thought to be about 100% specificity. Lastly, the most important pillar in addressing the question whether this is IIH or not is to measure the CSF pressure. Where I work, we tend to get the patient in the typical left decubital posture with hip flex, and as we introduce the needle, as you are securing yourself into the CSF starts to come out, you ask the patient to relax their hips because that's very important. Having their hips quite flexed will falsely raise the CSF pressure. The Vietnamese in 2008 thought about that, say, well, is there any way we could predict the CSF pressure with hip extended rather than hip flexed? They asked the group of people, they LP'd them with their hip flex and checked the pressure, and then asked to extend their hips. And they suggest that using this equation of multiplying the CSF pressure inflection by 0.89 could give you a rough guide where the pressure is in extension. Is relief of headache after LP diagnostic? Any ideas? Yes? No? No? Good. So it's supportive rather than diagnostic according to the ICHD. And why is that? Well, specificity is about 77%. And I've seen a couple of cases of migraine patients who typically don't have any symptoms at all of raised CSF pressure. They had the LP and they feel relief after the LP. Why is that? I'm not quite sure. Finally, when you think of other possibilities that could kind of give rise to raised CSF pressure as well, I would think, I always kind of go for a full blood count, biochemical profile, and TSH as a baseline for every single person who comes through the door. Males and obese male, you need to think about obstructive sleep apnea. Taking a good medication history is very important as well. Finally, I'm going to suggest some about 4 articles which were kind of really helpful when I was preparing for this talk, and I find them quite helpful in kind of a quick review for the condition. Thank you.
Thank you, Dr. Mudar, for this nice presentation. And I think we have time for some questions.
Yes.
Doctor, how frequent do we do lumbar puncture for the patient with IIH?
Okay, so the first thing is the diagnosis. So you need to get a baseline diagnosis test, and then we tend not to do serial LPs just for the sake of seeing where the pressure is, because once you start the patient on treatment, you will be guided by symptomatic relief in terms of their headache, as well as more importantly is the visual fields and the ophthalmological assessment. We tend not to do really serial LPs.
And on the long term, how frequent can we make it?
We don't recommend doing routinely CSF pressure unless the patient is really kind of, you're treating them, they're not responding, and you start to wonder, is there anything else?
Thank you, Mudar. I've been trained to follow them with visual fields, but now the ophthalmologists are throwing all the OCTs on us. Can we substitute the OCTs for the visual fields, or do we still have to depend on the visual fields, or how to go with this?
Where we work, we tend to do the both. We don't follow one and leave the other. We tend to do both.
And what about the MRI criteria you mentioned regarding the diagnosis of IIH? Would you still depend on them?
Pardon?
The MRI criteria you mentioned.
So those are supportive. So the most important thing is having the appropriate history to start with, and those will kind of guide your clinical acumen to say, well, yeah, that puts weight into your diagnosis. Yeah. So they are not really in the diagnostic criteria. They are more used as a supportive measure as well.
But you don't depend on them for some procedure like fenestration of the optic nerve sheet or something like that?
No.
You don't do these procedures?
Optic sheath fenestration.
Fenestration.
We don't do it where I work. We don't have an ophthalmologist that's trained to do that. So if we're going to go for a fulminant IIH with the pressure high, we just go for a shunt. Yeah, we shunt them.
So thank you. Any other question? Thank you, Dr. Mudar, for this nice presentation. And I think we move to the next speaker, Dr. Mena.
Next speech, medication overuse headache, a new name for an old problem, to Professor Robert Kwan, United States of America.
Go ahead. Dr. Khalil made my job a little bit easier because I don't have to review the differential diagnosis for medication overuse headache. But I do have to tell you, Dr. Khalil, as of this year, U.S. is no longer the most obese nation. We've been supplanted by Mexico. I'm very proud of that. Not really. So I'm going to talk about medication overuse headache today, and my only disclosure is that I have too many slides. So I'm going to speak quickly, probably not as quickly as you can speak, but pretty quickly, so that I can go through both the diagnosis and treatment strategies. The only thing I'm going to say about the differential is to keep in mind that it's just one of many options for secondary headache. While it's the most common among people who have migraine and chronic daily headache, it's always important to keep that differential in mind. So what do we mean by medication overuse headache? The first thing to note is that it only occurs in people who have an existing primary headache. So people who have, for example, chronic back pain and use daily anti-inflammatories are not going to develop a chronic daily headache from the overuse of medications or from the daily use of medications. It tends to have a self-sustaining rhythm of predictable and escalating medication use. So what we typically see is patients go from having episodic headaches to having a background headache through which we see these spikes of the primary headache. They tend to become increasingly frequent and severe, and they kind of lose the characteristics that we normally see in the underlying primary headache. And typically, when we stop the overuse, they revert to their episodic nature. Specifically, we think of medication use based on, we think of medication overuse as based on what the specific headache medication is that's being taken. So for simple analgesics, for example, we typically look for headache medication being taken more than 15 days per month. For triptans and ergots and opioids, the numbers are lower. In our clinic, we use 10 days per month for the triptans and 8 days per month for opioids and barbiturates. To give you a sense of where this data came from, it was an excellent study that was done by Marcelo Bigal about 10 years ago. And you can see the increasing curve based on how often you're taking the medications. So as I said, for opiates, it starts to have this angle of inclination at about 8 days, or 8 days per month, or 2 days per week. It's a very similar curve, but it's displaced to the north for triptans, and so that's why we use the 10 days per month as the upper limit for triptan use in someone with a migraine. And then for NSAIDs, it's very interesting because it seems that NSAIDs are actually protective at lower frequency uses, and when you get to a higher frequency of use, it starts to increase the headaches. So NSAIDs have a slightly different picture. What does MOH look like? Well, we see it mostly in migraine. It's less common in tension-type headaches, and in mixed headaches, still less common. The complaint you usually hear from the patient is that the medication that used to work is not working as well. So I used to get complete relief taking my triptans. Now they don't seem to work as well or as long. And obviously that leads to the increase in use. Also, as we see somebody chronify, we notice that they become more sensitive to their triggers. It seems that the threshold for pain goes up. It loses the features of the primary headache. So people who describe their migraines, they're one-sided, they're throbbing. The headache, as it becomes more related to the MOH, it loses these features. It's more of a global headache. It throbs when it's severe. Sleep gets more disrupted. And almost always there's a neck pain component. When we think of the clinical characteristics, obviously it's going to be daily or almost daily. The characteristic becomes more constant and non-throbbing, but when it gets severe, it starts to look more like it's migraine. And that harkens back to this notion that there are two headaches going on. There's the secondary headache from the medication overuse, and then spikes of the primary headache coming through. The intensity tends to be mild to moderate, and the episodes of migraine breaking through tend to be moderate to severe, as you would see with uncomplicated migraine. Tends to fluctuate throughout the day. It can be distractible, and it's often worse on awakening. This has to do with the short half-life of many of the rescue medicines and acute medicines that the patient is overusing. As I said, it loses its bilaterality, but you will have occasions when they're one-sided, and that's probably the underlying primary headache breaking through. If it's side-locked, I would think about a different diagnosis, hemicrania continua or something. It's very common for people with chronic MOH to complain about nausea and vomiting and other features that are migrainous in nature. And as I said, sleep disturbance is a very, very important clue. I think it's important to realize that MOH is not the same as a headache secondary to medication. It actually has a different classification in the ICHD-3. And very often, if you take a careful history, you'll find that they've started another medication, and the headache that they're describing is now different from their usual headache is a result of that medication. So it's important to ask about that. All of that being said, usually we think about chronic migraine as being associated with medication overuse. And in fact, that's true about half the time, and half the time it's not true. So when you see a patient who seems to be overusing and you get them to stop overusing and they still have a chronic daily headache, your job's not over. You have to figure out what else is going on there. Always give a patient who you think has medication overuse 2 diagnoses, whatever their primary diagnosis is, plus MOH, and then you revisit that once you've addressed the MOH. So these are just the diagnostic pearls to keep in mind. I've gone through the clinically fluid nature of MOH and the unpredictability of the location. I didn't mention autonomic symptoms. Actually, I have this slide to remind me, not you. I didn't mention the autonomic features. And very often when you see autonomic features, it will be after you've told them that they're overusing and they start to back off on the amount of medication they're taking. The non-restorative sleep disturbance is almost universal among patients with MOH, and behavioral issues are very important both in leading into MOH and in your strategy for having people withdraw from it. I don't have time to go into the pathophysiology. Instead, I can reference this article, which just came out this year and goes into the pathophysiology, I think, very nicely and clearly, addressing both the genetic components and the serotonergic elements in it. And this article, which references the plasticity of the brain in terms of both functional and anatomic changes we see in MOH and their reversibility when we stop the overuse in the patient. I'm going to spend the last few minutes that I have talking about the treatment. This is a slide that was referenced yesterday, and it's one of my favorite papers, but it very clearly illustrates the equation of migraine and the reversibility in moving from low-frequency episodic to chronic and back the other way. I think it's really important to remember that that's the nature of this disease. Some patients do get better on just advice alone. Even in our clinic, we see patients who are totally surprised when we tell them that the reason their headaches are worse is probably from overuse of medication. And they say, oh, well, I'll simply stop doing that. And they do. So that does happen. But for most patients, you have to come up with a plan to help them stop overusing. There should always be 3 elements. And it's best to start this with primary care. So education of primary care doctors is critical because by the time we all see these patients with medication overuse, they had help in getting into this mess, let's put it that way. They've not been properly educated as to the limits for medication use. So the essential elements: education, support, non-pharmacologic treatment, and pharmacologic treatment. And I can say unequivocally the patients who do the best are the ones who take the behavioral and lifestyle changes seriously. The patients who, in addition to stopping overuse, get on a regular sleep schedule, regular exercise, regular meal schedule. They're the ones who do the best and are least likely to relapse. When you think about the approach you're going to use for medication withdrawal, the big question is, do you do it as an inpatient or an outpatient? And we'll talk about strategies for both of those. Do we do gradual reduction or cold turkey? I'm not sure if that's an English expression or not. Cold turkey just means stopping everything suddenly. And then how you're going to manage the withdrawal-associated symptoms, and that will depend on what the medication is that's being overused. So when you think about which setting is more appropriate, inpatient or outpatient, I think the most important elements are motivation and the psychiatric history. How dependent the patient is on their medications, whether they're buying into the notion that it's actually the medication and not something more sinister. How long they've been overusing, that is a strong predictor of success. What they're overusing. Someone who's overusing opioids is going to have a much rougher course than someone who's using triptans too often. And then what's your backup plan? That's very important. How you're going to guide them through, what follow-up you're going to arrange. So advice, this is one study that was done in Italy, and they had 46 patients or 45 patients in 3 groups, and they found that the best outcomes were in patients who were admitted, the inpatient population. About 90% responded well. The other 2 groups, it was down around 60%. The gradual reduction versus complete detoxification, again, well-controlled studies seem to suggest that complete cessation of the overusing medication has the best results. It's much more challenging to have patients cut back because when your head hurts and you've got medication that you think can relieve it, it's really hard not to take the medication. So kind of a strict detox has a better outcome. As I said earlier, the withdrawal strategy will depend very much on the medication. In general, the resolution of MOH is better with things like triptans and NSAIDs and quicker than it is with opioids or barbiturates. We sometimes will use strategies such as corticosteroids and antiemetics, neuroleptics in order to bridge that period when they first stop medications. It's very difficult to get a patient to have a bottle of something available to them and not have them take it just on your word that they're going to get better after they get worse. It can be challenging, so communication's important. Chris Diener has done a lot of work showing the benefit of starting a preventive, and that has a strong effect on the best possible outcome. The best evidence is for topiramate and on a botulinum toxin. We don't have any evidence on CGRP monoclonal antibodies yet. So you start with education. Thank you. And detoxification, stopping the offending medication. Initiate a bridge therapy if warranted. Then establish limits on the acute medication because it's not going to cure their underlying primary headache, but they need guidelines as to what's appropriate. Initiate the preventive therapy, and most important, establish a follow-up pattern, usually with mid-levels, where they get reinforcement for appropriate behavioral changes. The non-pharmacologic strategies, again, there's no time to go through them all. This is a fairly good list. It's old, but it hasn't changed much in terms of the non-pharmacologic interventions. Rapid outpatient detoxification. This is one protocol that has been used. This is an off-label strategy, but there have been 2 studies that have validated it, and that uses 25 milligrams of sumatriptan 3 times a day as the bridge therapy, in addition to anti-inflammatories. Oops. Inpatient, it's a little bit more complicated. There's not time to go through it in detail, but DHE is still recommended as the go-to strategy. That's dihydroergotamine 45. And then we use an acute rescue with ketorolac for breakthrough pain. These are just some of the IV protocols that have good evidence. I wish I could go through them all, but there's no time. Weaning can work, but not very effectively. I think it's better to detox suddenly if possible. Thanks. Cold turkey with a bridge is really an effective technique, and that's when you stop the patient's overused medication abruptly. You put them on Decadron with a 10-day taper, maybe from 10 milligrams to 1, going down by a milligram a day. Put them on a preventive, and provide something for acute treatment. We use ketorolac. We don't use triptans in this setting. The prognosis is pretty good. You can see here from some data, but MOH does tend to recur. In about 1 in 5 people overusing triptans, you'll see them slide back over a year, and it can be as high as 70% for opioids. The greatest risk is in the first 12 months, and people at greatest risk seem to be males, people who've been overusing for many years, and people who have significant psychiatric comorbidities. So to summarize, treatment should include patient education. It's not enough to simply stop the medication. For people only overusing NSAIDs, sometimes advice alone is sufficient. People with significant psychiatric comorbidities tend to have a rougher time. And patients with psychiatric psychiatric issues are the biggest challenge. Whew. A lot of information quickly.
Thank you for your interesting lectures. Any questions, please? Any questions? Thank you, Professor.
Our next speaker will be Dr. Mauli Fall of Dakar, Senegal. He will be talking about secondary headache.
Thank you, Mr. Chairman. Good afternoon, everybody. First, I would like to thank the organizer to associate my modest personality to this very exciting international meeting. I would like to talk about secondary headache, but especially how to manage it in sub-African, Sahara African. First, headache has retained since 3 days. Headache was one of the common symptoms in neurology, and in our country, it is the first reason of consultation. But primary headache threatens quality of life, but secondary headache threatens the life or functional prognosis. That's why we can manage secondary headache, because through this studies in European Journal of Pain, the conclusion was secondary chronic headache seems to have various causes of depend of subtype, but we need to recognize that subtype of secondary chronic headache is of importance because it might have managing complex implication. In that case, we have to identify first the red flags, like in the acronym SNOOZE. After that, the SNOOZE is for the systemic symptoms like fever, weight loss, or secondary risk factor, and other systemic diseases like HIV or like ozonoplasia. Neurological symptoms or abnormalities can be found like confusion, impairments, alternance of conscience. And so we must be interested of the onset. Onset may be sudden or abrupt or going progressively. And after the age of patient is very important, new onset and progressively headache, especially in middle age after 50 years. Previously, historical headache is so important because first headache or difference may be given in change attacks frequently, severe or clinical feature. That's the importance of quality of historical in clinical examination as in our countries which have lack of specialties, lack of medicines or lack of investigation feature. And so we have to manage secondary headache in historical and examination. But it is very difficult in children and adolescents, which the majority was to evaluate headache complaint will have on the primary headache disorder. Important is around 90% of all headaches can be correctly diagnosed, but we have to do very carefully historical and very carefully physical examination. We must start with historical. The historical, first we will be interested to the onset. The onset is the begin syndromes usually begin before middle age, but in secondary headache, ominous etiological of headache occur more frequently with advanced age, that means over 40 years. The modality of appearance is very important because that may be progressively or thundering or standing. The duration also we must interest to it, and students onset also considered as with in sub-hemorrhage or meningitis. Gradual or chronic can give us ways to go to migraine or tension type headache, recently developing of several days, weeks, or months. The new onset migraine or tension type headache, cranial intracranial pressures, or temporal arthritis by the onset in elderly. The headache localization must be most helpful, but is not so specific. We can say it is bilateral or unilateral for the patient. An example for investigate the headache, secondary headache. It's the most common causes in our country is subarachnoid hemorrhage, meningitis, temporal arthritis in elderly, hypertension, glaucoma, traumatism, non-meningitic, and headaches can be done by more roles, but if any investigation warranted, when diagnostic may be very difficult or historical or examination suggests as some disorders, serious disorders, we must do some investigation obligatory. We first begin for the scan CT and lumbar puncture, blood examination, and MRI. The scan CT is more important and very accessible in our countries, and it gives us to diagnose the first common and dangerous headache, secondary headache. In this, if the headache is thunderclapping like hemorrhagical meningeal, hematoma, and tumor or sinusitis. Also, CT scan can give us other etiology of secondary headache like subdural hematoma, like space occupying lesion, even tumor or even abscess. And the etiology of secondary headache, one of the common is the ophthalmic artery aneurysm in the elderly people. The investigation is after CT scan, we do fundus and lumbar puncture. Fundus is very important to diagnose the pseudotumor cerebri or hemorrhagical meningeal if CT scan is normal, or also to diagnose meningitis. In elderly person after 60 years, fundus can give some other information, but the orthodontic disease and can be found also in the elderly person. If CT scan and lumbar puncture was normal, we can try to do the MRI. MRI in the second flare or echo gradient can give us more information in sub-hemorrhage, arachnoidal hemorrhage localization, or in the pituitary necrosis. We can do other sequence like arterial time or venous time to do successively angiopathy or aneurysm or dissection in the carotid, or in venous time to try to get cerebral venous thrombosis. We can do injection of gadolinium after NCF to try to get the CFF hypotension, but arteriography is not more common in our days now, but it can be useful, but it is to be discussed. In conclusion, we say quite enough secondary headache is very, very emergency, and some of them is played per in a minute. That's the importance of historical and clinical examination, suggests selective imaging policies, acute CT scan and fundus, not acute, we can try to do later MRA. Patients come with very emotional, but physicians must go to the evidence to do an orientation and earlier management that significantly can improve the evolution. That's the only way we allow us to avoid misdiagnosed secondary headaches. Thank you for your attention.
Thank you, Dr. Fall, for the nice presentation of a variant causes of headache. Any questions? I have only one comment that you mentioned that in the presence of a normal CT, the next step is fundus examination.
After?
This is real?
Yes,
You will do fundus examination after normal CT or before?
After normal.
After, يعني a patient coming in the emergency room, part of the examination is fundus examination.
Yes. Fundus is in the
You will not
examination.
postpone fundus examination until a normal CT comes.
Fundus is included in the examination, clinical examination.
What?
Fundus is in clinical examination,
In
but
the general
after this we
examination.
can do a CT scan.
Okay. Yeah. Okay.
Thank you.
Thank you, Doctor. Next topic, recent management of idiopathic intracranial hypertension, Dr. Salah Mahamada from Egypt. What is the problem? Okay.
Good afternoon. Thank you very much for the organizing committee and the panel for accepting a neurosurgeon to stand among neurologists. It's very scary for me to stand here, but hopefully I will survive. And it gives good hope for future cooperation and serial co-joint meetings between the two departments. My job is very easy. Dr. Modar talked about recent management of intracranial hypertension, so I'll skip a few slides because you'll feel like it's a deja vu of what you have just seen. This is the main building of our beloved Ain Shams University, the Supreme Administrative Building. And this is our Ain Shams University Specialized Hospital, where we all meet, where we all train, where we all try to help our patients. And I'm just a student of many great professors and colleagues that teach us every day how to become better clinicians and surgeons for our patients. Back to the principles of management of idiopathic intracranial hypertension. It's about principle base. It's not just about the information within. We have the main principle is to treat an underlying disease or a cause or modify the natural history of the disease if possible. And phase 2 is to protect vision. And phase 3 is to manage headache. This cannot be done by a single discipline or a single subspecialty. It needs the cooperation of all disciplines, specialties, neurosurgeons, neurologists, headache specialists, ophthalmologists, maybe social workers and dietitians to help get the best result for the patients. Regarding the symptoms, Dr. Modar Taban talked about it with great detail. The hallmarks are headaches and visual symptoms, and maybe an isolation or a combination of any of the other non-specific symptoms. Step one is the ophthalmological evaluation, whether the headache specialist or the neurologist or the neurosurgeon would do it himself or who would refer it to a formal evaluation by the ophthalmologist. It is the hallmark and the start point for any patient with idiopathic intracranial hypertension. We have seen about 20 minutes ago the different stages and the different grades of papilledema, starting from the near normal disc up to the grade 5 severe papilledema and established papilledema. According to the grade, you just get an impression of if this patient would benefit from conservative trial of management or a more aggressive trial of management. But you must exclude other causes of pseudopapilledema and papilledema like fundus. You must exclude malignant hypertension with the rest of the changes in the background of the fundus and the complete blood picture, because in anemia and polycythemia you might get similar fundus pictures. And then to the neurological examination, the only accepted neurological finding in diagnosis of IIH is 6-palsy. Any other neurological finding would just deviate our concern from an IIH to another similar pathology. Once you find a patient with symptoms and papilledema, especially if losing vision or having threatening of his visual capability, then an urgent radiological assessment is done, primarily to exclude surgically reversible pathology like a hydrocephalus or a mass, maybe other vascular lesions or meningeal enhancements that would exclude the diagnosis of IIH. However, what we call a normal MRI, it is not necessarily normal, as Dr. Modar said in his fantastic speech. You have different findings for what we previously called normal MRI. Now we have an empty cella. You can have a tortuous optic nerve. You can have the subarachnoid spaces around the optic nerve widened. You can have protrusion within the optic nerve head. Sorry, this slide. And flattening of the posterior globe, and also incomplete filling or stenosis or attenuation of the dural venous sinuses. After we have done a fundus examination for the patient, and now he is complaining of visual or headaches, and now he has papilledema, and he has a so-called normal MRI, the next step would be a lumbar puncture. Actually, the lumbar puncture is a diagnostic procedure. It is not a therapeutic procedure, and it is not a follow-up tool. It is just for diagnosis. The timing for the lumbar puncture may be a point for discussion. Maybe if you get a patient with very mild symptoms and very mild grade 1 papilledema, you might just start to try some medication before you subject the patient to the lumbar puncture with all its discomforting settings for the patient. And sometimes, no, it is a severe case from the start with fulminant course, then you might just run and do a CSF diversion through the lumbar puncture, partially diagnostic and partially transiently therapeutic. So this is the flow chart of the management in most cases. You get the papilledema identified, and then you go on to excluding other causes of papilledema and pseudopapilledema. You do the brain imaging to get what we call a pseudonormal MRI, and then you go for the lumbar puncture, the opening pressure, is somehow still debatable. Is it above 20 or above 25? But surely if it's above 25, then it's diagnostic. Maybe in the gray zone of 20 to 25, some might debate it's not high enough. Then you exclude the secondary causes, and now you get an IIH. IIH, you can have a fulminant course with visual risk. You can get the typical clinical picture of a woman in the reproductive age group with a BMI more than 30, or you can get someone who is atypical. If you got someone who is atypical, you just have to revise the secondary causes again before you go on to treat. If you have a patient with an IIH, all patients should be counseled and directed to lose a bit of weight. We'll get into this in detail. If the vision is threatened, then it is fulminant, then we must behave in a very, not aggressive, but very urgent manner. We can just make a temporary CSF diversion, or we can go to the more definitive managements. That's other than the patients who have no threat to the vision, then we try the medical treatment. As we said, weight loss induces remission in many cases, especially those above the BMI of 30. When you have a visual threat, it's a surgical decision. You are now trying to save the vision of the patient. We have no luxury to try medication, and the medication would fail, and in process we would lose some of the vision. I will not go into details of the lumboperitoneal shunt, ventricular peritoneal shunt. I will just say that in the States, maybe the optic nerve sheath fenestration is taking upper hand than the shunting process. But in maybe Europe and North Africa and Egypt especially, we in Egypt, we never did the fenestration. We always go for shunting. The question that was asked to Dr. Modr a couple of minutes ago, does it have a role for serial lumbar puncture? And the answer is no. There is no role. It's a diagnostic procedure, not for follow-up and not for treatment. Non-surgical management for the mild grades, acetazolamide, carbonic anhydrase inhibitor. Patients who can tolerate it and can tolerate it for a period of time and for a high dose get a very good benefit, but not all can tolerate it. And any patient in the reproductive age group receiving some sort of long-term medication should be counseled for the possible teratogenicity. Okay. Corticosteroids, it's a fading practice. Maybe 10 or 20 years ago, patients took longer courses of steroids, but a newer trend, maybe for 10 years, is not to give it for a long period of time because it increases the weight and it adversely affects the course of treatment, maybe for a short period of time at the initial diagnosis and in fulminant cases. Management of headache, as a neurosurgeon, I cannot step on the toes of headache practitioners and neurologists and speak about the details of headache management, but the most important thing is not to give medication that would alter the course of the disease, maybe increase weight, increase depression in patients. We must adjust our medication not to affect the treatment plan. يعني طبعا you are more oriented with this than I am, how to assess the phenotype of headache, and according to the phenotype of headache, that any of these can accompany patients with IIH. Most of patients, maybe 68%, according to one study in 2017, have the migrainous phenotype. So when you choose the anti-migrainous treatment, just avoid weight-gaining medication and depression-inducing medication and teratogenic medication. This is a very important issue. if a patient has IIH and he's been treated by a shunt and now he has acute exacerbation of headache, what should we do? Should we treat it as a headache patient or should we assess the shunt? Of course, it's the first thing that comes to our mind that the shunt is malfunctioning. So we have to assess the shunt function and assess as if it's a new patient. Follow-up and monitoring, I will skip this and go into this. It's according to the visual fields, according to the papilledema, and according to the clinical situation of the patient. It's not about remeasuring the pressure of the opening pressure of the lumbar puncture. The conclusion, as I said at my opening, it's about teamwork, it's about cooperation, and really we can minimize the morbidity burden and improve the overall quality of life for all our patients. Thank you.
Thank you, Dr. Salah, for your interesting lecture. Any questions, please? تفضل.
I just have a short comment. When you said for very mild cases you can consider treatment without a lumbar puncture, as a neurologist I'm completely against that. Because to make a diagnosis you need to measure the pressure. And then if the patient responds, okay, maybe not big problem, but if they don't, then you're always wondering if you have the right diagnosis. And since they're already on medications, it becomes a big mess. Lumbar puncture is a minimally invasive procedure. Just do it and get it over with.
I totally agree with you, sir. It's a trend. Maybe I do not personally agree with it, but in many clinical scenarios, especially maybe in young girls who are extremely afraid, extremely anxious, in cooperation with the parents of the patient, they might ask if we can just delay it for a week or two just to try, for example, acetazolamide for a couple of days. If she's getting better, then we don't have to go for it. I do agree with you, but sometimes the circumstances puts us in a situation that we can just accept another scenario.
Any more questions?
Thank you, Dr. Salah. Back again to optic nerve sheath fenestration, which was declined by Dr. Modar Khalil. How frequent you do it, and do you have any criteria of doing it other than visual loss? I mean engorgement of the optic nerve sheath in the MRI, for example.
Regarding optic nerve sheath fenestration, we have no experience at Ain Shams University doing it, and I don't know about anyone in Egypt doing optic nerve sheath fenestration. We all go for shunting. But according to literature, maybe if you have unilateral papilledema or more evident on one side, or you have papilledema without increased tension by lumbar puncture, they might go first for optic nerve sheath fenestration. And it's according to the preference of the institute. In literature, we read that in the US centers, they are more prone for optic nerve sheath fenestration, but in Europe and in Africa and in many countries of the world, maybe neurosurgeons, because it's common practice for us to place a shunt, whether ventriculoperitoneal or lumboperitoneal, then we prefer what we are accustomed to.
Any more questions?
One question, please.
Okay, one question.
It's about treatment. It's about the treatment. You use corticosteroid and acetazolamide, but what about topiramate? Have you an experience in using topiramate in idiopathic?
Actually, we in our institution we do not use topiramate for reducing ICP. We might use it for some patients with chronic headache after management of ICP. After placement of the shunt, the patient gets some sort of mixed types of headaches that you don't know if it's migrainous as 68% of the cases, or it's low tension headache, or. So sometimes we go empirically and use topiramate, and in most cases we get satisfactory results at very low doses.
So if I could comment, so topiramate is a carbonic anhydrase inhibitor.
Yes.
It's a mild one. And we sometimes will use it because we often see the combination of migraine and IIH. But the problem is when the patient comes to a neurologist and we suspect that they have increased intracranial pressure, doing the tap doesn't help the headache, which is why they came to us. So if you treat the headache and you don't make the diagnosis, is in support of doing the tap. If you treat the headache but don't make the diagnosis, then you may miss, you know, a progression to blindness. So I would agree, and in the U.S., we always would tap the patient if that's the.
I tap all my patients. I do agree.
Yeah. Yeah. And you're right. We are doing a lot of optic nerve fenestration. It seems less invasive, less risk of infection. So we are seeing a lot more of that.
Thank you.
Before leaving, I would like to tell you, Dr. Salah, that we are cooperating with the neurosurgeons in epilepsy surgery, in involuntary movement surgery, and previously for vagal nerve stimulation in epilepsy. So we are cooperating with you.
يا رب دايما. Thank you.
Okay, thank you for your lecture. Thank you.
وختامها مسك. My friend Dr. Deep Maxwell Kaid will talk about cervicogenic headache. What is it? And I really want to know what is it.
So they asked me to pick a topic, and I told them, whatever you haven't covered, please let me know. And I offered to talk either about cervicogenic or sinus headache, and they put me down for both. So I thought, great, I'll talk about both. And then I realized the time period it was allotted for it. So it's going to be both cervicogenic headache and sinus headache, and I'm going to zap through it, and it'll be purely clinically based, and hopefully it'll be helpful. We all know the ICHD-3 divides headaches as primary and secondary. The first 4 categories are primary headaches, and then you've got maybe 8 or 9 categories of secondary headaches. And why did I start by talking about nausea and migraine, whereas the title is cervicogenic headache? Because at the time, and about 20% did not complain of any nausea. We all know that nausea is part of the diagnostic criteria for migraine, and we ask about it: nausea, vomiting, photophobia, and phonophobia. But neck pain is not really in the diagnostic criteria. Well, if this is how common nausea is, how common is neck pain and headache? Neck pain can actually be the most common migraine symptom, despite the fact that it's not in the criteria. There was a survey of 144 migraine patients. 3 of 4 of these patients stated that they experienced neck pain along with their migraines. And not only that, 60% of them, the neck pain was the first sign of the migraine. And these people end up with chiropractors and osteopaths and wanting MRIs of their neck because they're convinced the neck pain is their cause of their migraine. In one study in 2010 with 113 patients, the neck pain was even more common than nausea, yet it's not in the diagnostic criteria. So in this study, to go over it briefly, they looked at the prevalence of neck pain at the time of migraine treatment relative to the prevalence of nausea.